Let's say you remove a mandibular third molar, the patient comes back a week later, and this is what you see. The workup and treatment today on the open reduction. Welcome to the Open Reduction, the channel covering everything oral and maxillofacial surgery. I'm Dr. Tom Bolten, and today we're going to talk about a bizarre complication after third molar surgery. This patient is a 45-year-old male who had pain, caries, and pericoronitis associated with a partially impacted tooth number 32. He underwent extraction of the tooth under IV sedation in the office, and there were no complications during the procedure. He came back a week later and told me things had been going well until about 2 days ago, when he noticed something growing in the area. It was painless, but he could tell something was there. I took a look, and this is what I saw. Okay, clearly this is not an extraction site that is healing normally. There's a large growth emanating from the surgical site, and it is asymptomatic to touch. It's slightly mobile, it's soft, and it has the look of disorganized granulation tissue. The first thing I'm thinking is an epilous granulomatosa. Epilous granulomatosa is a term to describe growth of granulation tissue from an extraction socket. They look very similar to pyogenic granulomas and are usually a reaction to bony sequestra in the extraction socket. Post-op radiographs demonstrate free-floating bone within the extraction socket, and the epilous granulomatosa is a reactionary lesion to these free-floating bone segments. This could also be squamous cell carcinoma. An extraction can cause proliferation of gingival carcinoma that mimics an epilous granulomatosa. Now that we've performed the clinical exam and started to put together a differential diagnosis, the next step is going to be to order some imaging. I obtained a panoramic radiograph, and this is what it looked like. We can see the soft tissue growth on the film, but otherwise the extraction socket looks fine. There is no retained tooth material, no foreign bodies, and no bony sequestra. So what's going on here? We have a bizarre growth from a 1-week-old extraction socket and no obvious reason. So I'm going to tell you that this is not an epilous granulomatosa and it's not squamous cell carcinoma. There is one detail I'm holding back, and it has to do with the patient's overall health. In fact, this patient has a systemic issue that's directly contributing to this growth. The question is, what health problem could cause this? Do you think it is A, a bleeding disorder, B, poorly controlled diabetes, C, advanced HIV or AIDS, D, an autoimmune disorder, or E, nutritional deficiency? While you're thinking about it, please take a minute to click that like button and also subscribe to the channel, The Open Reduction. By hitting these buttons, you're letting me know that you're benefiting from this content, and it also helps this content reach more people. Back to the question at hand. What is the most likely systemic issue that contributed to the growth of this lesion? If you said A, you got it. This patient is a hemophiliac. Specifically, he suffers from hemophilia A, which is a deficit of blood clotting factor 8. The lesion we're looking at is actually a walled-off hematoma. Obviously, I knew the patient suffered from hemophilia A prior to the procedure, so I coordinated this case with the hematologist. He received a factor 8 infusion 1 hour prior to the surgery and also used Amicar in the perioperative period. There was very little bleeding during and immediately after the surgery, and he told me when he was home he didn't bleed much either. However, on post-operative day 5, he woke up with a mouthful of blood. A hematoma developed, and the body subsequently began to form granulation tissue around the hematoma, resulting in this growth. When I began to remove this lesion, it popped, and there was dark red blood within the lumen. I removed all of the poor healing tissue and the hematoma, curetted the site, irrigated, placed gel foam, and then advanced a mucoperiosteal flap to obtain a watertight closure. The specimen was sent to pathology, which confirmed no neoplasm. I saw him back 2 weeks later, and the site had healed appropriately. Thanks so much for watching today's video. Please leave any comments or questions below, and check out my channel where there's lots of other interesting oral surgery cases just like this one. I'm Dr. Tom Bolten. I'll catch you next time on The Open Reduction.